Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call, and today Dr. Tom Inglesby returns to the podcast from his work in the White House. He speaks with Dr. Josh Sharfstein about what he learned in government, the state of the pandemic today, and why Congress needs to move quickly to appropriate more funds for the response. Let's listen.
Dr. Tom Inglesby, it is so great to have you back on Public Health on Call. It's been a while.
It's great to be with you, Josh. Yeah, it has been a while. Glad to be back on the show.
Now, you're not just back on the show, you're back at Johns Hopkins. You want to tell our listeners what you've been up to lately?
Yeah, so back in December, I was set to come back from HHS to Johns Hopkins, but then I got asked to join the White House COVID team for some months. So I was with the White House COVID team from December until about 2 weeks ago. And then I came back to Johns Hopkins, back to our Center for Health Security.
So you were at HHS for how long?
I was at HHS from February until December. I was working some part-time at Johns Hopkins in the fall, but on the HHS COVID team from February till December in one form or another.
So it's been really over a year since you've been back full-time at Johns Hopkins and able to spare some time for the podcast. So I guess my first question, though, is what's it like in there? What's it like to be part of the government response to a pandemic?
It was really compelling work. I was, first of all, really impressed with the people who work in government on a permanent basis, the civil service. They really keep the government running. They are experts in budget and legal and in program management. And so it was a real treat and an honor to work with that team of people. And it was also true that the political leadership that they brought in across HHS and in the White House, really super people, great values, really hardworking. Those are tough jobs too, because they really have to make difficult calls, a lot of trade-offs, a lot of pressure, a lot of time pressure, but really enjoyed the people. And of course, the mission couldn't be more compelling, trying to diminish the impact of COVID on the country through vaccine programs, testing programs, operations of government. And I got a chance to really dive deeply on testing program issues, especially in the last 5 months, because my job at the White House was coordinator of the testing programs for the White House COVID team.
So you were there as vaccines rolled out across the country. You were there as testing scaled up tremendously. I imagine, though, it's been frustrating not to see the COVID support come through in Congress as the administration has been asking.
Yeah, that has been a real surprise to me. I think if you look back in the first year of the pandemic, the Congress funded a number of emergency supplementals for the COVID response during the end of the Trump administration. So one after the next. When this administration started, there was a big supplemental that started off the COVID response in January of 2021. And there hasn't been a request really since that time. That request was made really with the understanding that it wouldn't necessarily last for the entire duration of COVID. We needed to see what would happen and how long it would last and what would be needed. And so the administration was talking to Congress about this supplemental for quite some time and then submitted a formal request in February. And unfortunately, here we are in May, and there still has been no action to support additional work in COVID. And so what that means is that there's no money for buying additional booster shots for the fall. There really isn't money for changing the vaccine to adapt to new variants. There's no money for long-term testing infrastructure, for the uninsured fund, for the new antiviral therapies that are coming down the pike that may be even more effective than the ones that we have now. So there's a lot of really important things that should be done, can be done. They just depend on new funding.
There's a little bit of a sense of fatigue with the pandemic now, and the hope perhaps that, it's just going to keep going down and doesn't really pose as much of a threat to the country. How do you think that has played into the difficulty in getting Congress to appropriate more funds?
I think it's probably a real factor. And I think it's certainly true that people are tired of thinking about and planning around the pandemic and would like to be doing other kinds of work. It is also true that we have more tools than we've ever had in the pandemic. We have more vaccine. We've really readily available vaccine across the country for now. We have antivirals, we have masks, we have tests. So we have many tools. So that's good. But to have those tools remain available and effective will require additional funding from the government. These tools are kind of dependent on that. And we also need to be completely prepared for additional surges or variants that may come. They've been very unpredictable in the last year. If you go back a month before Delta or a month before Omicron, they were not visible. So there's not a lot of warning time should a new variant arise. We all certainly hope that we won't see variants like Omicron, but we don't know whether we will or we won't. And so our job in the government and the people who work on COVID outside the government is to be ready in the event of a new surge. And the way to do that is to stay prepared and to have new products be coming down the pipeline, vaccines that can adapt to new variants. And we're not going to be in a position to do that unless we get more congressional support. So you're right. There is a hope that we're kind of like in a linear trajectory towards, ending this pandemic. And unfortunately, there is no way to predict that. And even now, we're seeing signs of potential trouble in South Africa. We're certainly seeing signs of rise in the United States from BA2 in New York State, New York City, Puerto Rico. 44 jurisdictions out of 64 have had a greater than 10% rise in cases in the last week. So we can't afford to be complacent.
Well stated. And I hope perhaps even by the time we're airing this podcast that there's a lot more movement in Congress on this request. I want to ask you about a tool that we have not had really yet, in part because we just have the ingredients for it, which is called test to treat. We've had testing, we're just getting scaled up in treatments. Can you talk a little bit about what test to treat is and what it will take to turn that into like another major part of the US response to COVID?
First of all, the good news here is that antivirals were approved at the very end of 2021, one of which is amazingly effective and has the potential to reduce hospitalization or death in people with underlying medical conditions by approaching 90%. And so that's a really dramatic outcome from an antiviral. We don't usually see numbers like that. Initially, Paxlovid was relatively scarce and had to be directed in very limited ways when it was first being produced. But now we have a very abundant supply of this antiviral. And it is now available in something approaching 30,000 locations in the United States. And so now we have different challenges than we did in the beginning. First of all, we have an awareness challenge. I think the public hasn't had this kind of product available for most of the pandemic. And so now that it's available, people aren't used to it. They don't necessarily know that they should do something about it when they get tested. So kind of informing the public that there is this really important antiviral available for people who would benefit from it, that's really important. Second thing is physicians don't know enough about it. Some physicians do, but many physicians, healthcare providers, nurse practitioners who could prescribe this, they don't know enough about it. And HHS is doing its best to really reach out to professional groups to spread the word about it, to get people much more familiar with it. It's not a long course of treatment. It's 5 days, twice a day medication, but there are some drug-drug interactions which are important to go through with patients. For example, cholesterol-lowering medications, you don't want to be on both of them at the same time. You can stop your cholesterol-lowering medication for 5 days. So there are parts of it that just need to be explained, but it's not a terribly difficult drug to understand. And then we have availability, making sure it is available for people when they test positive, because you need to take this medication within 5 days of testing positive. That's how the FDA has authorized it, because that's how the studies were done to show benefit. And so what the administration is doing right now and what the president announced in the State of the Union was a new test to treat program, which is, broadly speaking, it includes all of these efforts: education of providers, education of the public, and expanding access to the medications. But the key element, or one of the key elements in the Test to Treat program, is setting up thousands of one-stop shops where people can walk in and get tested, get seen by a provider, and get dispensed those antiviral medications all in one place and go home with the pills and start taking them after that one visit. There are now thousands of places where you can get that done in pharmacies. If you think of minute clinics or any place in a pharmacy where you can see a doctor for something, relatively minor that's bothering you, essentially all those locations, or almost all those locations now, are able to dispense Paxlovid. And in addition to that, there are tens of thousands of pharmacies that also now carry Paxlovid. Online, HHS has a treatment locator where doctors or patients can go in and they type in their zip code, and you can see all the pharmacies around you. I think in my neighborhood, there are 10 pharmacies within 10 miles of my house that carry Paxlovid. And for people who have doctors, they can call them on the phone and say, I just tested positive. Can you prescribe Paxlovid for me? The doctor may say, I want to see you, or they may say, well, okay, that's all I need to know, and I will call that prescription into CVS or Walgreens or whatever pharmacy is near you. So it's a complicated program just because you have to get tested, you have to get seen, you have to get treated, but the administration is doing everything they can do to try and reduce the complexity, make it available, get the word out. And the good news is, as compared to 8 weeks ago, 8,000 treatment courses of Paxlovid were distributed and 80,000 treatment courses were distributed this week. So 10 times as much Paxlovid is moving to people now as it was, but we know that that's not enough. It is a major goal of the administration to make that happen.
Thanks for walking through. The idea is a lot of people may just be finding out that they're positive for COVID, and then that's the window to get them treated right there. And I don't know whether you agree with this. Some people think that the sooner you get treated, the better, that you don't want to wait till day 5. It's better that you're treated early with the antiviral. But at any rate, the ability for anyone to be able to get the treatment quickly will matter. And one question that's come up is what to do for people who don't have doctors. And we've seen in the pandemic that there have been equity challenges at every stage, like with the vaccine rollout or the testing rollout. And so with the Paxlovid rollout, how do you help people who may not be so well plugged into the health system, may not just be able to call up a doctor and have them call in a prescription, don't have easy access to a pharmacy with a minute clinic? Are there approaches that can help them get a hold of a medication that could be very helpful to them? Ideas like a protocol for the pharmacist to give the medicine, for example.
Yeah, I think the FDA is reviewing the experience with Paxlovid so far. Their initial judgment was that it was important for a healthcare provider to be in the loop in these decisions because of the potential for drug-drug interactions and the potential for the complexity of the medicines to, kind of cause trouble for people. They certainly were committed to reviewing the experience pharmacies and the public was having with Paxlovid. So I don't know whether that decision will change, but that has been an FDA judgment up until now. I'm hopeful that with more data coming in and kind of reviewing the experiences of people, that we could get to a point where pharmacists would be authorized to provide medications, provide Paxlovid in this way. But I think, ultimately FDA is going to be trying to make that judgment. In the meantime, there are state-run sites where people can get tested and seen and treated for free. And HHS has asked all states to set those sites up. There are also, for people who are in the Department of Defense or work for the VA or who are kind of cared for by the Indian Health Service, all of those large organizations have free test to treat options. But you're right, Josh, this is a problem that's become much harder to manage because of the end of what was called the uninsured fund. There was a fund set up through HRSA and HHS, which managed basically paying for claims related to testing and treatment and vaccination for people who didn't have insurance. And that fund ended about 2 months ago. And since that time, I think there have been a lot of attempts to try and figure out new solutions for people without insurance, depending on the issue, whether it was vaccine or whether it was testing. Many people who were using the uninsured fund for testing have now tried to shift over to other free testing programs that still exist. Really, it's quite unfortunate because it's created many barriers for people who were using that program, but there are some other options out there. It's just a lot more work for people to have to find them and travel to them. And I think that's why the uninsured fund was part of the original supplemental request that went to the Hill, continued funding for that. But that does not appear to be in the initial proposals that are circulating now.
Yeah, that's not good. Well, I feel like I could keep you on this podcast for quite a while to catch up. But let me ask you one last question, because I think people would be mad at me if I just didn't get your overall sense of where COVID is going from a global perspective, what the key issues are, how you're feeling about the course of the pandemic around the world.
So overall, if you kind of look at the overall numbers in recent weeks, really recent months, there really has been a lot of improvement in most parts of the world since Omicron. A lot of variability, much more variability than there was last year, where you kind of see things happen in one part of the world and then predict it somewhere else. So there is more unpredictability now because we have different vaccination patterns in the world. We have different experiences with immunity and when the disease came and how many people were infected and how old is the population. So overall, we're in a better place. Again, we have more tools in some countries, although low and middle income countries still, have far too few tools as compared to what they should have available to them at this point. Even with this kind of general trend in the right direction, in the US and in Canada, numbers are going up again. And that is from currently BA2, which is circulating, or subvariants of BA2, which is itself a subvariant of Omicron. So things are moving up. And again, in 2/3 of the jurisdictions in the country, they're moving up, not at the same pace as they moved up with Omicron, but still moving in the wrong direction. What remains to be seen is whether we have a rise in hospitalizations that we saw in earlier surges. Hopefully, the level of vaccination and the prior immunity that was generated in so many people after Omicron will protect many people, even those who are positive, from getting sick enough to be hospitalized. But you see that not only in the case numbers and in some states in rising hospitalization numbers at lower levels, but you also see that in wastewater surveillance around the country. That also does suggest that we are looking at a rise in cases to some extent. Over the horizon, the other thing that's a new variable is what's happening in South Africa, with a relatively steep rise from new subvariants, BA4, BA5, which are, again, subvariants of Omicron. And it's still too soon to really get a sense of the overall, how high will this new surge go? But if you look at the pace of the rise is very worrisome. It's a fairly steep rise. And that's in a country where the great majority of people have either been infected or vaccinated. So we got to watch South Africa carefully, got to watch BA4, BA5 carefully. We know we have both of those in the US at a very, very low level currently. And how BA4, BA5 have an impact in the US when we have different vaccination patterns, different immunity patterns, remains to be seen. But definitely another reason why we can't have this complacency that we're done with COVID. We're in a better place, but we are not done with COVID, and we need to be prepared for whatever might come next.
Dr. Inglesby, it's great to have you back at Johns Hopkins, helping us all prepare. And thank you for your service. And thanks for joining me on Public Health on Call.
Thanks so much, Josh.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McClusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.